Hi, everyone. Welcome. Thank you for joining us tonight. My name's Lauren. I'm with Theraplay, and I'd like to introduce our speakers for this evening. We have Erica Desper. Erica founded Confident Parenting in 2012 as a certified baby and child sleep consultant, offering group and private counseling for families struggling to get their baby or child to fall and stay asleep. Erica has supported hundreds of families in and around the main line and Philadelphia area and internationally to improve the quality of their family's sleep. She is also mom to son Jaden, who, as a baby, was very good at crying and not very skilled at sleeping. She was recently named Best Sleep Consultant by the Mainline Parent Community and Family Favorite Sleep Consultant by the Philadelphia Family Community. We also have Nicole Brackman, who's an occupational therapist joining us from Theraplay. She joined Theraplay in February 2019 and has previous clinical experience in school-based and early intervention settings. Nicole obtained her Bachelor of Science in Health and Occupation and Master of Science in Occupational Therapy from Elizabethtown College. Nicole is particularly interested in feeding and occupational therapy's role in this practice area. Due to this interest, Nicole has engaged in continuing education opportunities for feeding, including the sequential oral sensory, or SOS, approach to feeding, and advanced courses related to GERD and autism spectrum disorder. Lastly, we have Tammy Leeper. Tammy received her Bachelor of Science in Nutrition at Arizona State University and completed her dietetic internship with Maricopa County Public Health. Tammy specializes in maternal and childhood nutrition, picky eating, and feeding challenges related to autism. As the mom of an adult son on the spectrum, she is intimately familiar with the challenges posed with sleep and nutrition in autism. And just a few housekeeping things. If you have any questions, please feel free to send them in the chat box or the question box. We'll be answering them throughout, and we also have a few questions that were sent before that we'll be answering at the end. So without further ado, I'm going to turn it over to Tammy. And we're going to talk about autism, sleep, and nutrition.
Oh, there we are. Lauren, can you hear me okay?
Sure can.
Okay, perfect. Okay, I was on mute. Sorry. Well, hi, thank you so much. My name is Tammy Leeper. I'm so excited to be with you all here tonight. I'll be talking about autism, nutrition, and sleep. And as Lauren had mentioned, it's a topic that I am really familiar with as I have an adult son on the spectrum. He struggled with sleep most of his life, but it was exceptionally difficult when he was younger. He didn't sleep through the night until he was almost 8. As you guessed it, I was awake most of those nights with him, and I'm pretty sure I'm still catching up on that sleep. So today I'm going to talk about the prevalence of sleep disorders and autism, the potential causes, an etiology for those sleep disturbances, the role of the GI tract, nutrition, and microbiome. And then we'll also talk about lifestyle nutrition strategies that are currently being used by major autism programs around the country. Okay, can you move to the next slide, Lauren? So sleep concerns, or the lack thereof of sleep, create a real challenge, not just for the child, but for the family unit, the caregivers, teachers, and any other specialists that they work with. Sleep deprivation may increase their behaviors, impact learning, and lead to health problems. For the parent who is often up with the child, this can cause concerns with their own health and increase the risk for parent and caregiver burnout. Next slide. So although as a sleep-deprived autism parent or caregiver, you might feel alone, know that you are not. The prevalence of sleep disorders and autism is somewhere around 50 to 80% of autistic in adults struggle with sleep. This includes falling asleep, staying asleep, and frequent waking. Okay, next slide. Okay, so why do these challenges exist? When Carter was first diagnosed, most of the time I was being told it's just part of the autism. And that was 25 years ago. We know a lot more now. There really isn't just one reason. There's a few. And these range from those neurobiological concerns, sensory overload, coexisting medical and mental health conditions, and medications. Next slide. Okay. So neurobiological impacts include neurotransmitter production, sleep-wake cycle dysregulation, and genetics. The neurotransmitters, those are little chemical messengers in our body that tell our body what to do, essentially. And autism research has found differences in the levels of these neurotransmitters present in those with autism compared to those that don't have autism. This includes the neurotransmitters serotonin, glutamate, and GABA. And these relate to sleep and other behaviors. Now, serotonin is the precursor to melatonin, which is the primary hormone in that sleep-wake cycle. So there's definitely some dysregulation there if you don't have enough of that particular hormone. And much of the research is finding that these things are the result of genetic expression or mutations, polymorphisms. Now, sensory overload is something that's very common in individuals on the autism spectrum. Our children and adults with autism are very sensitive to light, sounds, touch, input. So at bedtime, things like background light or a noise down the hall, or even the weight or feel of sheets, blankets, pajamas, these may all be overwhelming and they could prevent the child from falling asleep. Now, sleep may be disrupted due to coexisting medical conditions. Some of the most common ones are GI disorders, such as reflux, diarrhea, constipation, pain, and discomfort. These occur in about 20 to 70% of the autism spectrum population. For example, with GERD, that acid reflux pain can persist for hours after a mealtime, especially if you're trying to lay down. The individual may not be able to express or articulate what's going on, especially if they're nonverbal, and it's certainly going to keep them awake. And then mental health conditions also occur frequently with autism spectrum disorder. These include anxiety, ADHD, depression, and these may lead to wakefulness. It could be part of the condition. For example, if an individual has bipolar disorder, during a manic phase, they may not be able to sleep. Or if it's part of their medication regimen, that may be interfering with their sleep. Okay, and that takes us to our next topic, medications. So medications, they have all sorts of effects on our body, including interfering with sleep or causing drowsiness at inappropriate times. And some of the more common ones that you're going to see with our kiddos on the spectrum are things like steroids, which are often used to control inflammation and allergies. Right now, or during cold and flu season, you're going to see the cold and cough medications, perhaps with Sudafed, that will definitely keep them awake. Headache medication can often contain caffeine, such as Excedrin. And then if the child has ADHD, perhaps the stimulant medication they're on, such as Concerta or Ritalin, may interfere. Now, there are also medications which make them sleepy and they may not be sleeping at the appropriate time, so they're awake at night. And that includes your depression and anxiety medications such as Lexapro or Celexa, and then clonidine and butamide, which are often used to treat high blood pressure, but they're very commonly used off-label for autism spectrum disorders. Okay, so what is the role of the GI tract in nutrition? These two really go hand in hand as one affects the other. It's really hard to separate out the two. What we eat and digest affects our digestive health and our nutritional status. But it's also thought that our digestive health may be directly or indirectly responsible for the food that we're choosing to eat or even the quantity of food. For example, a child with chronic constipation may have a poor appetite and secondary malnutrition. I think we might have skipped over a slide. Okay, there's one missing. Oops, sorry about that. Okay, well, there are other factors that impact an individual with autism, and these include nutrigenomics, feeding challenges in the microbiome, and we'll just jump right into the nutrigenomics. So this is a really new, exciting field, relatively new in nutrition, that looks at the interaction between genes and the foods we eat, and the emphasis is really on disease prevention and treatment. At the heart of this is the genetic polymorphism, and this can impact the way our body responds to things. But I want to describe what a polymorphism is, and that's what a difference in the DNA sequence that changes how the body does something. So, for example, in PKU, the body, there's this genetic code that changes how the body will process the amino acid phenylalanine, or it will change how nutrients like folate and folic acid are metabolized. And then there's this, it affects how foods taste, and that includes cilantro. I don't know if any of you are one of those individuals who can taste soap when they eat cilantro. That's due to a genetic change that affects olfactory receptors. Okay, all right. So sleeping, nutrition, and feeding are very intertwined. The prevalence of feeding disorders is about 70 to 80%, and there are, as also with sleep, a few reasons that this occurs, and that includes sensory, GI disorders, swallowing and functional concerns, including dental pain, and those types of things. And these children may have nutritional deficiencies because of their selective feeding that further exacerbate some of those new neurobiological concerns that were mentioned earlier. And there are interventions that can help with feeding. Okay. Now, the microbiome is really cool. Although we don't have all the answers for autism etiology, we are learning about the potential role played by the microbiome and the gut-brain axis. And I'm going to start with a little bit of vocabulary. The microbiome is the sum of all microbes in all the world. And the microbiota is the unique population of microbes in an individual. And then the gut-brain axis, this is this connection between our brain and our GI tract via the vagus nerve, our immune system, neurotransmitters, and other chemicals produced by the microbes in the gut. Now, our microbiota, our individual microbes, are affected by our environment, diet, exercise, and medications, or even if our mother had a C-section or breastfed. There are hundreds of species that exist in the world, and some are more beneficial than others. The beneficial ones will produce chemicals that reduce inflammation, influence our brain health, and even give us essential vitamins like B12. But the less helpful species increase inflammation and impact our immune system in a negative way. There can be a dysbiosis, which creates pain, discomfort, which may lead to feeding and, of course, sleeping concerns and increased inflammation. I'm a nerd. I'm going to throw it out there and own it. I get quite excited anytime I see any research about the autism and the microbiome. Microbiology was one of my favorite classes. And it's super exciting to me that there's a lot of research going on here at ASU. Researchers have identified that for individuals on the autism spectrum, they have a higher prevalence of those less beneficial species and fewer of the beneficial species. One study at ASU showed an improvement of GI symptoms and autism-related behaviors using microbiota transfer therapy. So essentially, they wiped out the individual's gut colonization with antibiotics, and they replaced it with a more beneficial colony from a healthy donor. In follow-up studies, improvements were still present at least 8 weeks post-therapy and beyond that. So that was a pretty exciting study. So the microbiome and, there we go. So we can help the gut be healthier, and that starts with improving the diet. These different species of beneficial bacteria thrive and prefer specific foods, and there's certain food groups that they really prefer. And that includes the ones that are listed here: fiber, omega-3s, polyphenols, tryptophan, and then of course fermented foods and probiotics. Research is finding that the greater variety of plant-based foods in the diet means that we'll have a more robust variety of friendly species there in our gut. So fiber is something most people know about. It's the indigestible parts of food, the fruits and veggies that we eat and the whole grains, but they're totally digestible to these bacteria, and they will use them as fuel and metabolize them. Omega-3s, it's also something many people have heard of, and there's a couple different types, but what's most important to know is what foods have them. And that includes fish, nuts, seeds, like flaxseed, chia seed, and then some plant oil, such as canola oil. And then you can even get them in supplemental form through krill oil, fish oil. Polyphenols are the plant chemicals responsible for many of the vibrant colors that we see in the fruits and vegetables, and they support our health. Foods high in polyphenols include berries, grapes, nuts, cocoa beans, and legumes. Now, tryptophan is an essential amino acid, and it's essential to neurotransmitter production, and these foods include fish, eggs, poultry, dairy foods, nuts, and seeds. And then fermented foods. No discussion on the microbiome is complete without talking about these guys. They help introduce and replenish those healthier, beneficial species. And fermented foods include yogurt, tempeh, kefir, and sauerkraut. Now, high-quality probiotic can also provide a similar benefit. Different strains provide different benefits. So working with a medical provider or a dietitian to find a probiotic that fits your individual situation is critical. What else can we do? So we can take a look at diet, mealtime routines, caffeine intake, and lifestyle factors. So we want to have a diet free from any contraindicated foods. So if the child has been assessed for GI disorders, we want to make sure that we're not giving them anything they're allergic to or that can trigger those GI concerns. Some treatment protocols recommend a diet that is gluten-free and casein-free. Some even are soy-free. And this has been helpful for a subset of children, but not all. And if your child is a picky eater, this one will take more time as you work through food acceptance. But when removing items from the diet, you must be careful to address any nutritional impact. For example, that soy dairy removal, you want to make sure that you are still providing some calcium sources for them. And then that you're supporting that microbiota. Navigating this can be a little less tricky if you're working with a feeding team that includes feeding therapists, such as an OT, speech, and dietitians. Now, routine in general is important for kids, and mealtime routine is especially critical here if there are GI issues. Laying down too soon after meals can exacerbate GERD, so timing meals so the last meal or snack of the day is well before bedtime. Plan for lighter meals later in the day, with perhaps lunch being the robust meal of the day. For those with constipation and GERD, activity after those meal times can assist with transit time in the digestive tract, and that can help relieve symptoms. So it might be beneficial to plan for light activity after meals if possible. You also want to look for hidden caffeine and food, caffeine sources in food and medication. You know, we think of the obvious sources as coffee, tea, and soda, and we're not likely not giving those to our kiddos, but they can also be found in chocolate and some of those medications. So even those tiny amounts that are in perhaps like a candy bar can be problematic for a child. The American Academy of Pediatrics has recommended that children limit, in general, their caffeine intake and totally avoid any energy drinks. Lifestyle to me means activities and routines, and these can really help with sensory overload, and some of these do circle back to sleep and nutrition. So the bedtime routines are super important. Screen time from computers, TVs, and tablets can interfere with that melatonin production. And right now with the current situation, there's a lot of kiddos doing online therapies and schooling, so it may be hard to limit that screen time, but turning them off about 2 hours prior can really reduce that stimulation. And then the current recommendations for physical activity in children is about 60 minutes most days. And while that's stated for overall health, there's definitely a benefit to sleep, digestion, and appetite. However, activity too late in the day, too close to bedtime can stimulate the child. So focus on having that activity earlier in the day. My parents told me I was a fun mom because we would get up, we would go to the pool, we'd go rollerblading, walk around the zoo, and I had such a great time with them. But really my motivation was tiring her little brother out so that he would sleep better, eat better, digest better. Um, and then bedtime routines. When we're consistent, these can help the child to transition, and soothing routines such as quiet music and baths are super great. Epsom salts in the bath have been traditionally used to help individuals relax, but they're now being looked at as a component of care. They contain magnesium sulfate. Researchers believe that low sulfate, which is an essential nutrient to cellular function, is something that's happening in autism. So they did a study where they had participants soak in a warm bath with 2 cups of Epsom salts and some baking soda twice a week for 20 minutes. And this actually helped increase those plasma sulfate levels. And it was, that intervention itself was part of some other things that were going on, but that study did show improvements in sleep. Okay, next slide. Okay, now I'm often asked, are there specific foods or nutrients that may be helpful? And here are my top picks for nutrients that may be beneficial. I'll talk a little bit about their role in the body, food sources, and if applicable, any supplements that are available. Magnesium is an essential nutrient. It does play a critical role in bone health, nerve transmission, and muscle contraction, as well as a host of physiological pathways. Some research and animal studies have shown a benefit to sleep quality and with a role in melatonin production with magnesium, but also with binding to the neurotransmitter GABA. And calcium plays a role in muscle relaxation, and it is often used to treat leg cramps, constipation, and muscle pain. So it may help calm and relax an individual. Now, it's commonly found in leafy greens, whole grains, dairy, nuts, and seeds. Most Americans are likely not consuming enough of this nutrient, and lower levels are also seen in those with digestive conditions. So our kiddos on the spectrum may be getting a double whammy with a restricted diet and digestive conditions. And the amount recommended per day does really vary depending on age and gender, but it starts as low as 30 milligrams a day in infancy and goes up to about 420 milligrams per day for an adult male. Supplements are available and should be used with caution. They can interact with medication and can have side effects such as diarrhea. And it is contraindicated in those with kidney disease. So it's important to work with a PCP or a dietitian to identify if a magnesium supplement is appropriate for your child. Vitamin D also plays a critical role here. Emerging research is finding roles related to sleep, although not well understood at this point. Studies have shown a relationship to sleep quality and that low vitamin D level. Improvement in sleep did occur with supplementation in some studies, and it is thought that the vitamin D may influence the production of melatonin. Now, this nutrient is manufactured by our bodies with skin exposure to the sun, but the time of year, our skin tone, our age, even like where we're located, our latitude, can affect our body's ability to absorb that UVB light, and certain medical conditions can reduce our ability to produce vitamin D from it. So deficiency is quite common, even in very sunny areas such as Phoenix, where I live, because of clothing and sunscreens, and we really don't spend a whole lot of time outside these days. Food sources include salmon, eggs, dairy, and mushrooms, and the amounts found in foods are typically low, so supplements are generally available in D2 and D3. The recommended amount for children is about 600 to 1,000 IUs per day and 2,000 IU for adults. Now, melatonin and tryptophan kind of go hand in hand here. If you recall, I mentioned earlier that melatonin is the hormone that directs that sleep-wake cycle. And our body's own production of melatonin may be affected by a number of things, such as screen time, shift work, age, and weight. But diet also plays a role, and the chemical precursors for melatonin include the amino acid tryptophan and vitamin D. As mentioned earlier, tryptophan-rich foods are chicken, eggs, cheese, and fish, and seeds. And there are also melatonin supplements available. And there's actually quite a bit of research supporting use of melatonin. for up to about 4 years to support sleep, and the doses range from like 1 to 6 milligrams. And I really encourage families to work with their doc or a dietitian to really identify what's going to be appropriate. Now, I'm going to talk briefly about these next two, CoQ10 and carnitine. The research is emerging regarding mitochondrial dysfunction in autism and oxidative stress, both of which may have a role in sleep. If you recall from biology, the mitochondria is the powerhouse of the cell. Oxidative stress is the damage caused by free radicals in our body. So antioxidants can help neutralize these free radicals. And CoQ10 is a naturally occurring nutrient that serves a role in the mitochondria to help produce energy and as an antioxidant. It is found throughout the body, but can also be found in salmon, tuna, liver, and whole grains. It's also commonly available as a supplement called ubiquinol. Now, carnitine is also being studied to support the mitochondria, and it is found in beef, chicken, fish, and dairy. And research presented at the Autism Conference in Phoenix last year, it was stated that both of these nutrients were beneficial in regards to sleep, but for some could increase hyperactivity. And so I would say proceed with caution. There may be a genetic component here. Okay, so it looks like my time is almost up, but I just want to close with the following. In the world of nutrition, it can take about 10 to 20 years from these studies that I'm talking about to go from that research and publication to when they're fully implemented in clinical practice. So I encourage families to stay the course, keeping up with the emerging research as best you can. I know how hard it can be. But as an autism parent and a dietetics professional, I really encourage working with your treatment team to evaluate and identify concerns that we talked about. And this includes genetic testing to help identify any genetic basis for concerns, because that in turn can help direct to more appropriate treatments. That genetic testing may yield that a certain treatment isn't beneficial, but another one might be. So you don't waste valuable time trying things that aren't going to work. And it's estimated right now that over 1,000 DNA changes may play a role in autism. This high number of variables likely plays a role in why some treatments work for some and not others. Thank you for your time tonight.
Thank you so much, Tammy. Okay, Erica, we're going to turn it over to you.
Okay, great. Hi, everyone. Tammy, that was great. I am a brain science geek, so I totally understand you geeking out on that science. Okay, so I am here to help you parents understand. I have a tough sleeper myself, so I can relate. He is now 10 years old, but he's been a sensitive sleeper all his life, so we are always a work in progress. And I know how very frustrating that can be, so I want to give you some solutions you can start to implement right away. Obviously, diet is an important component in terms of why kids may be struggling with sleep, but I want to help you understand some other really common causes. The most common reason I see babies and toddlers and older children struggle with sleep is that they are growing a bit too tired before they fall asleep. Now, I know you're thinking, but my kid's not overtired. He's bouncing off the walls, or she has, she's an even more fun version of herself. She could go for hours. It really helps to understand what overtiredness does and doesn't look like. Some of us have kids who will show very openly when they are overtired. Those are the kids that are melting down, rubbing their eyes, yawning, falling apart. Not all of us have those kind of kids. So I have the kind of kid when he's overtired on the inside, he looks absolutely fine on the outside. He may even look like a better version of himself, like he could fly, he has wings. So if your child leading up to bedtime or younger child leading up to nap time is extra happy, extra silly, extra hyper, just know that they could be tricking you in terms of whether the timing that you're using is ideal or a little too late. So overtiredness does not always look like overtiredness. Now, why does it matter? Because there are hormones involved. So Tammy touched on the fact that there is a hormone process that regulates our sleep-wake cycle. We want those hormones working for us and for our child, not against us. So think of your child's tiredness like a wave in the ocean, and you are a surfer, you are a boogie boarder, you're going to wait for the right wave, and you're also going to wait for the right moment to paddle into it, because what you want is a nice, smooth, long ride. What you don't want is a wipeout. If you paddle into that wave too early or too late, you will not get the same smooth result. So a lot of times when we are struggling with sleep, we're paddling into our child's wave of tiredness too early or too late, and in most cases, it's the too late side, and the ride to sleep will be a lot rougher, or perhaps even unsuccessful. So when we're talking about timing of sleep or schedule, how do we decide if our schedule is part of the problem? If our child is not necessarily letting us in on that fact, then how do we decide? The one thing you want to think about, what is my child's natural wake time in the morning? And are they falling asleep at bedtime the night before at a time that would allow them to get an ideal total of sleep? And you can pull up, a chart online of what your child's sleep needs probably are for their age group. Most, from babies to elementary school age children, I can generically say most kids are going to need around 11 hours overnight, give or take a little bit in either direction. But let's just say, for example, you had a child that probably needed 11 hours. And let's say they wake up at 6 a.m. every morning, but you get them down to bed at 8 or 8:30, which is not unreasonable. But if we're counting back, that's not going to allow them to get the 11 hours. And what's going to happen is every night they lose a little bit, which stacks on what they lost the night before, which stacks on what they lost the night before that. And they accumulate what we call a sleep debt, which is very much like a financial debt. It gets very hard to pay down from there, and it starts to work against you. So we want to think about sleep totals, make sure we're aiming to get them down at a time that if all the stars aligned and everything went well, they could in theory get the right total overnight. You also want to make sure you're using clock times that match your child's natural rhythm. We all have an internal clock, and while it varies from person to person, it dictates for each of us where sleep is going to go well. So as an adult, you've probably experienced staying up way too late. You can't wait for your head to hit the pillow, but then when it does, you're just wide awake. All you want to do is sleep, but your body has now kicked into overdrive and you just can't sleep. So babies and toddlers often need to be asleep for bedtime earlier than 7:30 or by 7:30. Again, this is all very generic. Haven't met your child. Whereas older children, 3 may need more of an 8:30 bedtime. And of course, as they get older, that time starts to creep later. But part of the problem, if you're waiting to get dinner done and waiting for both parents to get home from work and everything's creeping later than, what all your best friends are doing with their kids, find out what typical bedtimes are. If you have other kids that slept well in the past, think back to what their bedtimes were, especially with a pandemic raging around us and no semblance of our normal schedule. I've seen a lot of clock times shift a whole lot later. It's also summer, so it's light later, and sometimes we shift with the sun, which doesn't necessarily work for our child's internal clock. So we want to think about totals, and we want to think about clock times. Timing is at least half the battle. To wrap up the timing and move on, you want to make sure, and Tammy touched on this, whether you have a typical child or a child who also has something underlying like autism, all children, all humans really, need to walk through a few predictable steps in the same order leading up to bedtime. The brain and the body need time to transition from I'm awake and I'm playing and I'm running all over the place to I need to wind down and transition into a sleepy phase. And for kids that are sensitive, the predictability is really going to be key. So if you feel like you don't have that in place yet, take some time to think about what would our evening look like. We wrap up dinner, we get cleaned up. When we go upstairs, what are the steps going to be? Maybe it's bath, tea, jammies, read 2 books, sing 1 song, say goodnight, and have limits on each of those elements too. We don't want to read an undefined number of books every night because that encourages them to have a case of the one mores. We want to have a defined number of books every night. Be very careful about screens in the room especially, but also too close to sleep. As Tammy mentioned, the light emitted from really any screen, and the closer you hold it to your face, the more of an impact it's going to have, tells the brain to wake up, just like sunlight does. at a time when we want the brain to be preparing for sleep and releasing hormones for sleep. So ideally, you'd have at least a 1 hour span of time from when your child stops looking at a screen to the time you're hoping that they will fall asleep. I know Tammy mentioned 2 hours, so it depends on who you ask. I say at least 1, but 2 is better. Milk can be a little problematic if it plays a key role in assisting your child to fall asleep, or even if it's just a step that they strongly associate with sleep. So babies and kids love patterns, and the brain loves patterns, and we all wake up throughout the night. So when milk plays a really key role in the bedtime process and routine, a lot of kids then will wake overnight wanting to repeat the step of milk again. So when possible, you want to wrap milk up downstairs, maybe have it with dinner, after dinner, say goodnight to it, put it in the fridge, leave it where it lies, and we go upstairs and do our routine separate of milk. Now we want to think about your child's sleep environment. So we have timing, we have routine, make sure that's all in place. Now let's talk about environment. Make sure that they have one designated space where they sleep when they are at home. If you have a baby and you want them to sleep maybe in your room at night, but their room during the day, that's fine. That's 2 designated spaces. But the point being, it's not the main area of the house. It's not bright. It's not noisy. There's not lots of stuff going on around them. And make sure that sunlight will not be dictating when your child wakes up or if they can fall asleep at all. We're in a season right now where it might be light beyond your child's ideal bedtime, or it might be light prior to their ideal wake time in the morning. You really don't want their sleep to shift with the sun because it will cut into those clock times and those totals that we touched on earlier. So you can buy fancy, expensive blackout curtains. You cannot. You can use thick black trash bags and tape. It doesn't have to be pretty, but you do want to make sure that it's dark enough that if you opened a book to read the words on a page, you would not be able to read those words on the page. The exception, of course, would be a night light or special lights for sensory sensitive kiddos that need to have some light in the room. We're mainly talking about blocking sunlight rather than having some sort of light to feel, to feel safe at night. Also make sure it's not too cold, but especially not too hot. An easy test is just feel your child. They should feel cool, but not frigid. When we are too warm, we sleep very restlessly. So it's actually better to have the room be a bit too cool than it is to have it be a bit too warm. We can throw out specific temperatures, 65 to 70 degrees for babies and toddlers, 60 to 67 for adults and children. However, there's so many variables that can change that. What are they wearing? Are certain rooms in the house warmer than others? So it's hard to say numbers for sure. I think a better test is to just see how they feel to the touch. And generally, if it's a comfortable sleeping temperature for you, it will be for your child as well. The sleep environment matters because of that factor I mentioned before. None of us sleep straight through the night. We go through 4 different types of sleep. And when we're shifting from one to the next, we move through what's called a partial arousal, which means we wake up just a little bit. And when we wake up just a little bit, we check our surroundings. Maybe we fluff our pillow, we roll over, we get comfortable again. If something's missing in our environment, let's say, for example, I fell asleep on a bottle of milk and I woke up and the bottle was gone. I fell asleep and mom was in bed with me and I woke up and mom's not there. If anything has changed, we are more likely to wake all the way up instead of partially. And then we want to address whatever has changed and we want to make it the same. So your goal, assuming that you have the timing in place and you're sure that that's working for you, not against you, you have a nice predictable routine in place, and you have made sure that your child's sleeping in a dark, cool, removed from the main area of the house environment, is to think about what's the last thing they see when they fall asleep? What are they reliant on to get to sleep? And is that still present when they wake throughout the night? Your goal is to make the environment they drift off in look and feel exactly the same as the one that they fall asleep in. So if you have music on at bedtime and it cuts off 15 minutes later, you're going to either want to find a way to rope it all night, leave it all night long so it's present each time your child transitions between sleep cycles. Same thing with lights. If there's a light on and then after they're asleep, you come and turn it off, Some kids are going to do fine with that, but a lot of kids are going to notice my light is off. I need you to turn it back on. So look for that constancy, that consistency with what's in their environment. And then the big question becomes, and I know this is one of the questions that came in advance, well, what if I'm the thing that's missing from my child's environment? So it's really, really common, I just want to reassure you parents, for your child to need you, or at least prefer to have you there as they fall and also return to sleep throughout the night. If you don't mind it, I don't mind it. But if you're here, maybe you do. So I want to give you a couple tricks you can use to work your way out of that. Whether it's a baby or a toddler or an older child, there are ways that you can adjust their expectations, and you can do it gradually. And hopefully avoid some of the drama that you may think will be part of this. I would focus your efforts on bedtime. Bedtime is pretty much a dress rehearsal for the overnight. So it wouldn't make sense to your child, especially your older child, if you stayed with them at bedtime and then when they woke up 2 hours later, you said, no, I'm not doing this again. It will actually make more sense if you practice not staying with them at bedtime and then repeat that in the middle of the night versus, only one or the other. So one thing you can do to stop assisting your baby or your child to fall to sleep and or back to sleep is what we call trading down sleep association. So think about what their current association is. Maybe, for example, they fall asleep in your arms and then you lay them down in their crib or on their bed, or maybe you're in the bed with them. Think to yourself, what's the next rung on the ladder that we can move down to? Maybe I'm going to have them get in their crib or bed and I'm just going to sit beside. Instead of us being physically together like this, I'm going to sit next to you, hold your hand, rub your back, talk to you, sing to you, whatever. This is the slow process, by the way. You're just trying to do one level down from where you are now. Not dramatic enough that your child will lose their mind, but a step closer to where you want to be. But then you're still stuck on that rung. So you want to kind of come down from there. If I'm now sitting next to you and I'm assisting you to fall asleep that way, how can I wean off all the touch and the talking and the singing and all that I'm doing? Can I just be a presence sitting right here beside you? And we've worked our way out of the touch. And if you want to look up this strategy on your own, it's often referred to as the sleep lady shuffle or the chair method. I often call it the fading method because you are gradually going to fade your presence out of the room. So in the case of a child in a crib, you're just going to start moving yourself further and further away from the crib every few nights. Give yourself and your child 3 nights to get used to something and then make another change. Maybe now I'm sitting halfway between the crib and the doorway. Maybe a few nights later, I'm in the doorway. In the case of a child in the bed, you can do the same thing. If they're old enough to understand rules and things like that, you can say, strike a deal with them. Hey, if you stay in your bed and lay quietly, I will sit right here until you fall asleep. So we can kind of fade or shuffle our way out of the room. You're trying to reach an end goal of your child. You've weaned off the touch, then you start moving yourself away, but they still have your voice to rely on and they can still see you. And then you kind of move out the doorway and a few nights later out to a spot where they can no longer see you while they're falling asleep, but they can still hear your voice. So they can check in. Mom, are you still there? Yes, I'm right here. It's time to sleep. And they very, very slowly have gotten used to letting you be just a bit further away and do a little bit less than what you did before. Now, some of you might be laughing at that and saying my child would never cooperate with that, but that is one gentle way. Is that we can sort of fade our support down. So you can shift from feeding to sleep to rocking to sleep to sitting beside you to get you to sleep. And then you can kind of shuffle your way out of the room. If that strategy is not appealing to you, maybe you want something a little bit faster, you can try a check-in approach. So this works especially well with a verbal child, but you can do it for nonverbal children too. You do your nice predictable routine, you tuck them in and say goodnight. You do step out of the room, either your child's contained in a crib or they're old enough for you to say, for example, I will come right back, but you have to stay in your bed and wait for me. And you come back really quickly. You're trying to get them to stay calm. You're trying to get them to trust the process that even though you're not there like you usually are, you're not far away and they don't have to wait long for you to come back. So don't try to trick them if you try this strategy. You are coming back. you are coming back quickly, you can give yourself a job to do. I'm just going to go use the bathroom. I will be right back here to check on you. And then you come back. You're doing great. I'm just going to go check on your sister. I'll be right back to check on you. You're trying to very slowly let them get used to you stepping away, but also with the promise that you will be back. And over the course of nights, you can, as they start to trust the process and relax about letting you step away, you can start to wait longer and longer and longer. And eventually, we usually reach a point where we tuck them in and say goodnight, step away, and we don't even need to come back because problem solved. I will say, especially the older your child is, it is important to choose changes that you're going to make at bedtime. And then, like I said, practice those same changes when they're waking up in the middle of the night. You want your child to choose to accept this and to adapt to this. So if you're doing different things in different places, that may cut down on their willingness to accept the new thing versus the old thing that's still happening. So really try to choose something that you can be consistent with. And I believe, I was trying to go quickly through that. Hopefully that gave you some helpful tips to implement right away. And I will turn it back over to Lauren.
Thank you so much, Erica. That was great. We are just going to get Nicole up. And all right, Nicole.
All right, guys. I just wanted to say thank you to Tammy and Erica. That was great. I took a lot of notes, so I'm sure that everyone attending also learned a lot. Thanks, guys. So we're going to be talking about occupational therapy's role in these two areas, including feeding and sleep. So as an OT, I have this really diverse kind of skill set and the ability to kind of address these areas. It's great. So we help various clients, in this case in the pediatric population, develop skills to function independently, as independently as possible in a variety of activities and roles. So we address a wide variety of skills and areas, but for the purpose of our presentation, I'll focus on sensory processing, sensory integration skills, regulation skills, and how that impacts sleep and feeding. Occupational therapists treat in a very holistic manner where we address the multiple facets of the child in this case. So we look at the environment, the child, the activity, and how they're all interrelated based off the skill set that the kiddo has. Lauren, if you can move to the next slide for me.
You got it.
Thank you. All right, so these are our traditional senses. So this is what makes up our sensory system, which is rooted within our central nervous system. So the first step is proprioception, and this is our joint and muscle awareness system. Secondly, we have vestibular processing. So this is movement processing, things like swings, slides, inversion, those sorts of movements that get our head in a different plane from our body and provide input to our vestibular system. Our tactile system provides input to our touch processing skills, vision, obviously our sight, and then we have auditory or sound processing system. We have taste and smell, which are both very closely related. Our final sense is actually the interoception. That's our eighth sense. This provides the ability to perceive and interpret our internal system. So these are things like feeling how our heart is racing, feeling our temperature. Are we hungry? Do we need to go to the bathroom? So this looks at how our internal systems interact and our awareness of those symptoms. So these sensory systems provide information about our body, our own body, as well as the environment around us. So these are deeply rooted in those experiences related to sleep and related to feeding. Lauren, you can go to the next one then. Okay, great, thanks. All right, so senses can fall in a few different categories here. So we can be over-responsive, under-responsive, and seeking in different areas, right? So if your kiddo say they avoid tactile processing. So they don't necessarily love to get messy. They don't necessarily love to have their face dirty or do arts and crafts, but they're always moving, right? So they avoid one system and they seek another. So these aren't mutually exclusive. So we can go either way with kiddos. But your over-responsive kiddo is, they're the kiddo that might be a little bit sensitive. So they avoid activities that provide, multiple forms of input or a lot of input to their body. So things like jumping and running. They don't really like to move around too much. You might describe them as uncoordinated. Moving downward, so an under-responsive kiddo might have like poor body awareness that results in clumsiness. So they're maybe not aware of where their body is in space and how to do things correctly. Their posture might not be the most effective, so they might not be the kiddo that's sitting up straight. They might be hunched a little bit. They don't respond as quickly to cues, that sort of thing. And then our kiddos that seek they're the ones who are always looking to move around, for example. They're bumping, they're crashing, they like rough and tumble style play, they're jumping off the furniture, or they prefer to be swaddled or in tight clothing. So all of these areas can kind of hit our different systems very differently. Those are just some brief ways to describe them. These all play a pretty big role in a kiddo's ability to regulate their emotions, right? So self-regulation is a person's ability to adjust their level of alertness and display their emotions and behaviors in response to that alertness. So these kiddos that have trouble may be described as erratic or impulsive. They may have a lot of meltdowns and you're uncertain what kind of led to this meltdown. So if we have difficulties processing, integrating, and organizing these sensory systems, that will likely impact our ability to integrate and understand our emotions as they're so related to one another. You can move forward then, Lauren. Okay, great. So there's two popular programs that occupational therapists will frequently use to address the skill of self-regulation. These two programs are deeply rooted in evidence, so they've been proven to be effective through multiple studies, that sort of thing. So the first is the ALERT program. So the ALERT program was designed by occupational therapists originally for a specific population. However, it has been generalized to hit kiddos from preschool age up until later school age. So they've tailored the program to meet kiddos with multiple needs or a kiddo that maybe doesn't carry any sort of diagnoses, but definitely has some of those characteristics of a kiddo that has trouble with regulating themselves. So this can be used for kiddos with a wide variety of diagnoses. It includes a series of lessons and activities that provide both sensory integration theory matched with cognitive theories for learning. So you're working towards having a kiddo understand these engine speeds of just right speed, running too high, running too low, and what activities get them to those points. So it runs through a couple different ideas and activities to adjust engine levels, as well as teaching parents how to carry over these strategies into the home. So the main goal of this program is so that kiddos can become more aware of how they can regulate themselves across various environments and become more independent in understanding exactly what they need to participate as fully as possible in this variety of environments. The second program that OTs frequently use is called the Zones of Regulation. So there's a couple main themes within this program. Those include things like managing the input of environments, understanding and regulating emotions, remediating executive functioning skills so that kiddos are better able to initiate, plan, and organize different activities they have to do. The zones of regulation also work towards increasing self-awareness. They work on the social thinking model for kiddos, as well as providing visual learning opportunities and scaffolds for kids to support those kiddos that maybe need some visual adaptations when they're learning a new skill. So this was designed previously for kiddos who had a wide variety of diagnoses. So kiddos who benefit from the zones of regulation include kiddos on the autism spectrum with ADHD, with conduct disorder, ODD, but can be applied to a much broader population, similar to the alert system that we had just touched on. The zones of regulation, rather than the just right, too high, too low, classifies different emotions into 4 zones. So they use a little bit different of a model to address that regulation skill to target sensory processing, executive functioning skills, as well as emotional regulation skills. So those are the 2 main programs that occupational therapists have utilized in order to teach kiddos and families more ways to regulate kiddos and have them participate a little bit more fully. All right, so apart from those 2 programs that really hit on self-regulation and awareness of emotional regulation, occupational therapists play a nice role in preparing kiddos for bedtime and for meals. So these 2 activities are deep sensory experiences. So they provide a lot of different forms of input for kiddos and can be either overwhelming or non-preferred for kiddos as well. So OTs assist in providing structured sensory-based routines to address the needs in these 2 occupations. So some of these preparatory tasks or changes to routines are prescribed based off the clinical assessment of the OT. We provide families with the appropriate frequency, duration, and structure of preparatory sensory-based activities to promote regulation prior to these challenging or maybe difficult occupations for kiddos. We also look at the environment. So maybe there's some environmental changes that can happen to promote more regulation in terms of the multiple systems, just in their bedroom or in the kitchen or mealtime routines, that kind of thing. Occupational therapists will also look at the routines similarly to what Erica had touched on, and trying to get an idea of any sensory-based routines that can be embedded within bedtime strategies, mealtime strategies, to assist in a little bit more participation there. Okay, perfect. I think we hit on everything related to OT's role.
Great, thank you so much, Nicole.
Welcome.
So we're about ready to wrap up. I just wanted to see if anyone has any questions or anything they want to ask any of our presenters. If not, you'll be getting a survey after the webinar. You can always respond back to the email that you got reminding you about the webinar today. If you think of any questions, we'll be happy to connect you with our different presenters. I want to thank Nicole, Erica, and Tammy for joining us tonight. This was fantastic.
I said thank you for having us, but I was muted.
I know, it's just, everyone does it.
Thank you.
Thank you so much, Lauren.
Well, thank you so much for joining us, everyone. Hope you and your families stay safe and well, and we hope to see you at our next webinar.
Hi, thank
Bye-bye.
you.
Yeah.